All right. I hope everybody can hear me. We're going to go ahead and get started tonight, kind of promptly on time. We're going to talk about just some common causes of knee pain that we see. We're pretty much going to cover most of the things that we see in the office that do cause knee pain. My name's Tom Pevny. I've been an orthopedic surgeon here in the Valley almost 30 years now, down with Valley View and this end of the valley for the last almost 4 years, but I see patients all over the valley. I have an office in Aspen, Mid Valley, and I do surgeries in the Mid Valley and here in Glenwood Springs, where I'm giving this talk from. And my practice mainly focuses on pretty much everything in the knee, from some of the simple things to very complicated things. And I also do a lot of shoulder work as well, mainly sports stuff, arthroscopic, instability, and rotator cuff. So before we get started, I know questions are always popular. So through your chat mechanism, you can send us questions. Some of those will be answered throughout the talk by Rachel Weimer, my physician assistant, and other ones we'll answer live at the end. And just to remind you also that this talk is recorded and a link will be emailed tomorrow. And it's also on our website. It'll be downloaded to our website where all of our talks, even over the last several years, are downloaded. So you could always go on that website and see a talk on pretty much anything orthopedic that you're interested in. And the next one of these talks will be sometime in October. I believe Dr. Potter, our upper extremity specialist, is giving the talk. We don't have a title yet, but it'll probably be on something hand or wrist. So let's get started. Let's see if I can move these. There we go. So knee pain is caused by multiple things. Very common cause of knee pain is overuse injuries that we'll talk about. We'll talk about cartilage injuries, and there's two main cartilages in the knee, and we'll go over the anatomy. The meniscus, which is the shock absorber, and the articular cartilage, which is the smooth bearing surface on the end of the bone. We'll talk about some traumatic injuries, such as ligament injuries, ACL, MCLs, and also bony injuries that we see. And then the last thing is degenerative, just wearing out of the knee joint. And this can occur from some of these above. If you have a meniscus or articular cartilage injury, it can lead to arthritis. Trauma can lead to arthritis, or it can be what we call idiopathic, where just over time, maybe because of a family history, genetics, which are a powerful thing, people develop arthritis in their knee joint. So we'll talk about anatomy. I'm big on anatomy. Really, the foundation of orthopedics is anatomy. In this way, you can see exactly what we're talking about. So all these anatomical pictures I'm going to show you are going to be from the right lower extremity. And this on the far left is looking at the right leg from the hip down to the mid-calf from the back. So you can see the big butt muscle, the gluteus maximus, and then the hamstrings. And then there's this window here where there's no muscle between the hamstrings and the calf muscles. These are called the gastrocs, gastrocnemius. And that's where all the bad structures in the knee live, the nerve, vein, blood vessels. So we kind of stay away from that part of the knee. And luckily, most of the things we see are more in the front of the knee or the sides and aren't in the back of the knee. And then if you look at the leg from the side, so this is a right leg looking at it from the side, and this white tissue that goes all the way from the pelvis, and it's really a continuation of this muscle called the tensor fascia lata. And it's kind of a thick fascial ligament, almost like tissue, and it spans both the hip and the knee, and it attaches to the tibia. That's called the iliotibial band. So because it spans the hip and the knee, the IT band can cause pain up by the hip, but also on the outside of the knee as well. And then this is the front of the knee with all the soft tissues on it. This is the kneecap. This is the quad muscles, and the quad muscles attach to the kneecap by way of the quad tendon, which is this big structure. And then the patellar tendon attaches the kneecap to the tibia, and that's what allows us to straighten our leg or extend the knee. And if we take all that tissue away and look inside of the knee joint, the knee is made up of 4 bones. The kneecap is one of them, but it's been removed for this illustration. And this is looking at a right knee. If it's bent at 90 degrees, you're looking straight at it. So the kneecap should be up here. but this is the femur bone, the tibia, and the fibula. So those are the 4 bones. There's also 4 major ligaments, the 2 cruciates, which are the main stabilizers of the knee, and they're called cruciates because they cross, and they're in this part of the femur called the notch. And this is the ACL, anterior cruciate, posterior cruciate. Anterior cruciate's in front, and it prevents the tibia or lower bone from coming forward, and the PCL prevents the tibia from going backward. So if you have an injury to this, it's going to cause front to back and some rotational instability. And then side to side stability is by way of the collateral ligaments. This is the MCL or medial collateral, and this is the LCL or lateral collateral. So 4 bones, 4 ligaments, and there's 2 cartilages in the knee. One cartilage is the meniscus, and if we look straight down on the meniscus, you have a medial or inside and a lateral. And this is what it looks like if you look straight down on it. It's these structures right here. So the medial side is a little bigger. The lateral side is a little bit more mobile and smaller and more C-shaped. Generally, they are hollow in the middle, so they don't go all the way across, but they're very important shock absorbers to the knee, and they have limited blood flow only to the peripheral 25 to 30% out here. So if you have a tear in here, those don't do so well and they don't heal. And this is what it looks like if you look at it arthroscopically. So if we're inside the knee joint, which we do all the time, this is the femur articular cartilage, tibia, and this is the meniscus back here, and this is a normal looking meniscus. And this is the other cartilage, the hyaline cartilage, and we have it under our kneecap. We have it on the end of the femur, on top of the tibia. And if you look at ice on ice, what we call the coefficient of friction, which tells you how efficient a material is as a surface. Ice on ice is 0.02. Articular cartilage, the coefficient of friction is 0.005. So you can see how efficient that is as a bearing surface. And that's what wears out when people get arthritis. And then the biomechanics, I'm not going to get into that in the knee, but they're pretty complex. And there's more stress in the cartilage, really underneath the kneecap more than any other cartilage in the knee, up to 6 to 8 times body weight, especially going downhill or downstairs. And so let's look at overuse injuries. We see this in runners and jumpers, and one of the more common ones is anterior knee pain or pain in front of the knee. And you can see the red here is right below the patella, so that's called patellar tendonitis, also known as jumper's knee. And that'll cause pain right in front of the knee, and usually it's from overuse, and you get little micro tearing, and the patellar tendon tries to heal, becomes inflamed, and can be very sensitive right underneath the kneecap. The iliotibial band, which we saw in those anatomical pictures, tends to cause more pain toward the outside of the knee. So again, right knee, and this red is where IT band. We see it in hikers, especially downhill, runners, even bicyclists, any kind of repetitive activity, especially if you have tight hamstrings or a tight IT band, can rub on the femur because the femur bone flares and gets wider in that area. And there's a little bursa, which is a fluid-filled sac that can get inflamed. So IT band is more to the side, patellar tendonitis more in front. And then what we call patellofemoral pain also causes pain in the front of the knee, but it's a little more deeper. It's like under the kneecap, kind of a dull pain. We see that in bent knee sport activities. So for example, at the end of ski season, we'll have a lot of people come in who've not injured their knee, but have this anterior knee pain. And it's because they've been in that bent knee position all winter, and they're loading that cartilage, which has a tremendous amount of stress on it anyway. And that's a very, very common cause of knee pain as well. The treatment for all of these are generally non-operative: activity modification, icing, over-the-counter anti-inflammatories or prescription anti-inflammatories. Physical therapy can be very helpful to stretch out the quad, the hamstring, the IT band, core strengthening, hip strengthening. Some of these Chopat braces work pretty well for patellar tendonitis, and also kinesiotaping or K-tape can be effective. And if that doesn't work, then there are some invasive treatments such as injections, either cortisone or what's called PRP, platelet-rich plasma, that can be effective, but rarely is surgery needed for those conditions. And so now we're going to look at the meniscus a little bit, and that's that shock absorber. And it has what we call type 1 collagen, limited blood supply, but it does have a very important function. It transmits a significant amount of load across the knee between the femur and the tibia in both bending and in straightening the knee. And we know that people that have lost their meniscus, even portion of the meniscus, there's a significant risk of developing arthritis. Again, wear and tear of the smooth cartilage because you don't have that shock absorber to protect it down the road. And so in an MRI, this is looking at right knee from the side. So here's your femur, tibia, and this structure here, this black triangle is the meniscus, and this is a normal looking meniscus. So if you look at this MRI on the right, you can see you don't have that black triangle in the back. It's actually sitting up here. We call that a bucket handle meniscus tear. And this is what a bucket handle would look like on an arthroscopy. Again, in relation to a normal meniscus, you can see this bucket handle where it's torn. The good thing about this one is you can see blood back here. So this is something we would want to salvage and repair because we'd have to take out most of the meniscus in this situation, which we don't want to do. So this is after we've put it back, and you can see these stitches that we've put into the meniscus, and this will allow that meniscus to heal. And most of the time now we're able to do this arthroscopically through just little poke holes. There's different techniques to repair the meniscus. Sometimes we will make a little incision toward the back of the knee. But either way, meniscus tear like that will do very well if you repair it. Even though the rehab early on is not fun, and recovery does take a good 4 months or so, in the long run, you want to salvage the meniscus if possible. But some tears like this one, you can see the tissue is kind of frayed. If you look at the articular cartilage, there's already a little bit of wear and tear, some mild arthritis. So if we try to put stitches in this, the blood supply is not very good. The tissue is friable and it's not going to hold a suture. It's not going to heal. So what we do in this situation, we do what's called a meniscectomy, where we just go in with our arthroscopic instruments, and we do this through 2 little poke holes around the knee, and we just clean up the unstable torn meniscus, leaving as much of the stable meniscus as possible. Because it's better to have a little less meniscus that's stable than to have these rough edges. Because if you continue to be active with these rough edges, it's just going to cause that arthritis to advance more quickly. So articular cartilage, which is arthritis, if it wear and tears over time, we do see acute injuries or traumatic injuries to that cartilage. And a lot of times the articular cartilage injuries, they can be isolated, but many times they're in association with other injuries in the knee, like an ACL tear or an MCL tear or other ligament injuries. And this one was isolated, and you can see this flap of articular cartilage. And articular cartilage, similar to the meniscus, has really limited blood supply. So if you have a full thickness defect, meaning where it goes all the way to the bone, has a very limited capacity to heal. So in this situation, and this is on the femur bone, and it's in a weight-bearing portion, we basically take out that flap, we clean off the bed, and we poke these little holes or drill holes into the bone. It's called a microfracture. That procedure has been around since the 40s and 50s. And really what we're trying to do there is stimulate blood flow. And you can see the blood coming out of this little hole. And what it'll form is like a scar ball in that area. The problem with a microfracture is that it's good for very small lesions, but the collagen, which is the structure that gives our tissues and our body tensile strength, ends up being a type 1 collagen, and normal articular cartilage is type 2. So it has a tendency to wear out over 5 to 7 years. So it doesn't really have great long-term results doing just a microfracture. So we have other options. And one of the options is taking plugs of bone and cartilage. So we took plugs here. You can see that's normal cartilage. Then if we bend the knee, like you see on the left side back here, that's where let me back up. This is where the defect is. And then we take the plugs that we took from here and we place them into our defect. And so we fill in that defect with normal cartilage. And that's called an Oates procedure or a mosaic-plasty. And the literature shows that these are very, very effective and good operations. And another option is to do what's called, it's really called a MACI now. So it's advanced a little bit from what this slide shows. But what we do is we go in arthroscopically and we can take a biopsy of the articular cartilage, and then we grow that cartilage in the lab. You send it off to Boston, and once they have a certain amount of cells, they send it back So that's after several weeks. So it's a two-stage operation. Then we go back, and if we have a defect like this that you see in the articular cartilage, we fill in that defect with the cartilage cells. And again, this is kind of an older technique where we'll take tissue and suture it into the defect, and then we'll inject the cartilage cells underneath it. Now we'll inject the cartilage cells and just put what's called fibrin glue. It's like a glue product over that defect. And that works very well too, but it is a two-stage procedure. And again, I'm just showing this anatomy again because we're going to talk about ligaments a little bit now. And again, the four major ones are the MCL, LCL, and the two cruciates. What really distinguishes the cruciates from the collaterals, besides their function, is that the collateral ligaments are what we call extra-articular. They're outside of the knee joint. So they're exposed to a different physical and chemical environment than the cruciates, because cruciates generally, not always, but they generally don't heal on their own. Whereas the collateral ligaments, if they're in isolation, which we see quite often, can heal on their own. And so an MCL injury is really the most common injured ligament in the knee. We all hear about the ACL, but the MCL is actually more commonly injured. But it rarely requires surgery, so it doesn't quite get the attention that the ACL does. And it's not as potentially career-threatening as an ACL. But it's usually from what we call a valgus force, which you see here. A lot of times it is contact, and like soccer and football, somebody falls on the outside of the knee goes in and it stretches out the inside and causes pain on the inside of the knee. And this is an MRI showing this black structure is the MCL and an MCL tear. But most of these can be treated with a brace, physical therapy, ice, anti-inflammatories, and a little bit of rest. They do take about 6 or 8 weeks to heal. And sometimes adding biologics like PRP, especially if you're a competitive athlete and you need to get out quicker to your sport, the biologics can be helpful. Now, the ACL tears, you guys have probably all heard of the ACL and ACL tears. A lot of athletes get this. And this is just a picture of a normal ACL. On the left, this is a torn ACL. It usually tears off the femur or the mid-substance really down on the tibia. And this is just a picture of a reconstructed ACL, where it's other tissue that's taking the place of the ACL. Now, if you look at the incidents, they're pretty common, especially in the younger age group, which you would expect because they're a lot more active. Interestingly enough, females are at much greater risk of tearing the ACL than males. There's now probably about 400,000 reconstructions a year, and about a fourth of these are from skiing injury. So the mechanism in skiing is usually getting in the back seat, which you don't want to do, because what happens is if your hips get below your knees, you try to fight that. And when you fight that, you have a huge quadriceps contraction, and the quad attaches to the front of the tibia. So it forcefully pulls the tibia forward, and that's what the ACL prevents, is from the tibia, the lower bone, coming forward. And it's usually the downhill leg. You'll catch an edge on the ski, which is just a huge lever arm, and it creates a significant amount of torque. So it's a combination of that quad contraction and the torque that tears the ACL. Unlike the MCL, most ACL injuries in like soccer, rugby, football, basketball, etc., are non-contact. They're usually either from poor landing mechanisms in sports, especially female sports like volleyball or basketball, or it's from a deceleration, rotation type of injury, like trying to fake somebody out. You can tear your ACL. And if we look at ACL tear by sports, you can see how women are much more common than men in all of these sports, especially skiing, to sustain an ACL tear than males. And the reason why is a lot of it is anatomic, intrinsic to that individual, meaning that their alignment is a little different. Women have wider hips than men because of childbirth. So that causes what we call a valgus, or kind of a slightly knock-knee alignment. That notch area where the ACL and PCL live is narrower. So if you hyperextend your knee, you can guillotine the ACL. The ACLs are smaller, so it doesn't take as much force to tear them. And certainly hormones are different in a woman than in a man. And that's been thought to be a contributing factor as well. One of the main factors in young women is actually poor neuromuscular control. They just have very poor landing mechanisms. Their muscles are weak, and they're hyperlax to begin with. Women are more flexible than male, so they can more easily stretch out and tear these ligaments because of the hyperlaxia, but also mainly because of the poor neuromuscular control. So how do we diagnose ACL tears? A lot of times just listening to the patient and hearing their mechanism of action of their injury. Most of the time I know what's going on. Certainly we always do a physical exam, and there's certain things like what's called a Lockman test or a pivot shift or an anterior drawer that tells us if the ACL is torn, and all of those things test for the tibia coming forward on the femur and for rotational stability. And we get imaging on most of these individuals. They all get x-rays and MRI as well. So this is an MRI of a normal ACL. Again, looking at the knee from the side, and you can see how it connects the femur down to the tibia. In a torn ACL would look like this, where some of the fibers are here and here, but you just don't see that continuous ligament like you do in a normal ACL. So how do we treat them? A lot of it really depends on the expectation of the patient. Some patients, if they're older, aren't really that interested in doing activities that are going to stress the knee. You may be able to get by with bracing and physical therapy. There are people out there also that are aggressive skiers without ACLs. We call those copers, but they're far and few between. Most people with an ACL deficient knee don't have confidence in the knee. They don't have stability. So most individuals, we do recommend surgery. Surgery in the past has always been a reconstruction, but in the last few years, repairing the ACL, especially with certain type of tears, if it tears right off the bone, you can reattach it to the bone, and there's different techniques for repair now that are showing pretty good results. So there has been a renewed interest in repairing the ACL. The advantage is that you maintain your normal anatomy, but I would say still by a good bit, by far, the gold standard is still what we call a reconstruction, where we use other tissue to act as a substitute for the ACL. And in people that are young, in their teens, up to 40 years old, we try to use their own tissue, what we call autografts. And the three main common tissues we typically take from the same knee that you tore your ACL, either the hamstrings, and a couple of the hamstrings actually come around in front of the knee, so we don't have to go to the back of the knee to get them, the patellar tendon, or the quadriceps tendon. So those are the most common autografts. And I've done them all in my career. For years, I did mainly hamstring. Then I kind of went to patellar tendon. But for the last few years, I've really focused on the quad tendon, because you don't have what we call the morbidity associated with a hamstring or patellar tendon if you take it from your body, meaning the pain, the weakness, etc. And it's a much stronger graft than the other two as well. And we're able to get it through about a 1-inch incision. Allograft is cadaver tissue, and the cadaver tissues these days are very safe. There's no increased risk of infection compared to using your own tissue. We really do not see rejection. So we do a lot of allografts in the older people that have ACL tears, mainly over 40 years of age. But regardless, if you do a repair or reconstruction, it still takes about 9 months to fully recover from an ACL reconstruction. When I started my career, we used to let people back at 6 months, but what we have found over the years is, which the literature supports, is that if people go back at 6 months, they still have a fairly high risk of re-injury, and it goes down significantly to 9 months. And after 9 months, it doesn't make a difference. So, and the reason 9 months is the key is because that graft we put in there, either your own or cadaver, it gets a new cell population, new blood supply. So it undergoes this biological process called ligamentization. And to fully mature, that takes about 9 months. And it also takes about that long for you to get your full strength back in the hamstring and quad in particular after a surgery. So that's why it takes 9 months. And so this is just a picture of a repair where we put stitches in the ACL and then reattach it to the femur. There's also a procedure called a Bear procedure, where you put in a porcine collagen, kind of a sponge material between the bone and the stump of the ACL that allows it to heal. So repairs are an option these days. And this is just a picture of a quadriceps tendon graft that we use for reconstruction. And these are just some pictures of once the ACL is torn, we go in arthroscopically. The ACL has two bundles. And so this is looking in that notch in the very back where the ACL attaches, which normally attaches right here. And these little circles just represent the two bundles of the ACL. And we try to recreate normal anatomy. So we drill this hole in the femur to kind of incorporate both of those anterior medial posterior lateral bundles. And this is just kind of right knee again. We put an instrument into the knee, and this is the femur. And we put in this little device that flips, so it spins, then we pull back on it, and it drills our tunnel in that femur. And then this is just showing kind of the progression of a torn ACL. This is that same little what we call flip cutter, but this is more on the tibia. This is after we've drilled the femur and passed sutures. This is after we flip that flip cutter. And this comes in various sizes depending the size of the graft. And then this is us just passing the graft. This is a little piece of bone off the kneecap where we take our quad tendon. And this is what the ACL reconstruction looks like at the end. And we're able to do that through these small little incisions. So this line represents the kneecap. Here's the femur, tibia. This is looking at the front of a right knee. So most people want a functional good knee, but it is very cosmetic as well if you're worried about that. And these are just some people that you guys recognize that have had reconstructed ACLs and have done well, from Tom Brady to Tiger, Lindsey Vonn. You can show 100 pictures, and our own Chris Klug, who won a medal in the Salt Lake Olympics, the local guy that had an ACL tear. They went on to do wonderful things. But the problem is not everybody does great in the long run. And what this graph shows is as we get older, age is down here on this x-axis. And here's a normal. OA is osteoarthritis. And what we would like is this to go straight across where nobody ends up in this bell curve, which is total knee replacement, is TKA. But what happens is if you tear your ACL when you're in your 20s, you're about 7 times more likely than the general population to require a knee replacement when you get into your 60s. And if you tear your ACL and the meniscus, that goes up to 15 times. So those injuries really have an impact on the long-term function of the knee. And this is a prime example, and this is actually a patient I did a knee replacement on today, but these are her preoperative x-rays, and this hardware is consistent with a previous ACL reconstruction. So she had had an ACL reconstruction and went on to develop, if you look at the space here between the femur and tibia, it's much narrower than it is on the other side here. So she developed arthritis, failed non-operative treatment, and ended up with a knee replacement. And so this is another type of trauma we see, more from the ski mountain, 54-year-old female. Looks like a pretty normal x-ray initially, but you can see the outside of the knee doesn't look as smooth in the inside. And if you look at it from the side, there's a piece of bone down here. So she has what's called a tibial plateau fracture, where the femur came down. And again, it has to do in women a lot with their alignment because they're a little knock-kneed. So when they come down hard on their knees, it's usually more toward the outside of the knee. And the femur acts like a hammer and comes down and beats up the tibia. And the tibia is pushed down here. And this is the meniscus. So this is called a tibial plateau fracture. On her, we went in arthroscopically, and you can see how far that's pushed down. And arthroscopically, we were able to elevate all that, and we're able to make it look pretty good. And you can see the meniscus back here. She had a little bit of fraying, but the main thing was that fracture. And then once we elevate everything, we fix it. In this situation with a couple of screws, a lot of tibial plateaus will put a plate on. And she did excellent. The interesting thing about this case is I saw her 14 years later. She came back because she had re-injured her knee, and she had a different injury. She had a meniscus tear, but her x-rays, you can see just like ACL and meniscus tears, if you have a tibial plateau fracture, you're at increased risk of developing arthritis. And if you look at the space toward the outside, this is where her fracture was that we fixed. We had obviously taken out her hardware in the meantime, but you can see how it's narrower than her other knee. And so when we see narrowing, that tells us that that smooth cartilage is wearing out and people are arthritic. So I had the opportunity to go back and re-scope her knee and able to look at what that cartilage looked like. It really didn't look too bad. And then we just ended up cleaning up her meniscus tear. So as an orthopedist, especially a knee surgeon, to me, I think of the knee joint as an organ similar to your heart, kidney, lungs. And when you get arthritis and that smooth cartilage wears out and you have exposed bone, it's really organ failure, not much different than heart failure. liver failure, kidney failure. And this is what it looks like on a scope where it's worn out. But a lot of times it's even worse than that, where you see exposed bone, and it's very painful. And you may think I'm crazy comparing arthritis to heart failure, et cetera. But if you look at this graph, it's pretty straightforward. It looks busy. And even though it's over a decade old, it's still very prominent. And what this shows is age again down here as we get older. And this is prevalence, just how common something is. And the main thing is arthritis is up here. So one, as we get older, arthritis is a lot more common than even depression, cancer, diabetes, heart disease. But the interesting thing is it's above this line. So this line right here demonstrates quality of life and impairment to being able to perform activities of daily living. So most people that have heart disease, diabetes, cancer, and depression are still able to do most of their activities of daily living. Their quality of life, even though they have a bad disease, is not overly compromised as far as activity. But if you have arthritis, it's significantly impacted. So that just shows you the significance of how arthritis affects our quality of life. And it's the leading cause of disability in the U.S. It limits everyday activity for millions of people. About a 50% chance you're going to get it in your lifetime. Very expensive to treat. But the sad thing is there really is no prevention and there's no cure for arthritis except for a knee replacement, which is the definitive treatment. So the symptoms are generally pain, swelling, stiffness. People get deformity, either knock-kneed, but what's more common is actually bow-leg deformity. Decreased activity because of pain. Because of this, you can gain weight. The weight gain and the pain can lead to depression or make depression worse. It can lead or make diabetes worse, and it can make heart disease and hypertension worse. So it has a lot of secondary negative effects. And the treatment always initially is non-invasive or non-operative. Weight loss is important. 1 pound you lose of body weight is 4 pounds off the knee. It's kind of how the math works. Activity modification, if you're a runner and you're starting to develop arthritis, maybe start swimming, riding your bike, do more gym activity. Physical therapy can maintain motion and strength. Anything to decrease inflammation like ice, the nonsteroidals like ibuprofen, which is the active ingredient in Motrin and Advil, or Tylenol, which is, or Aleve, which is a naproxen product, can be helpful. And Tylenol, if you can't take the anti-inflammatories, can help for pain. Sometimes bracing, what we call unloader braces, can be effective if you have arthritis on one side of the knee or the other. And if those things don't work, then more invasive treatment like injections. In my practice, we do a lot of knee injections in the office. Steroid base is still probably the most common. We do a lot of HA, which is hyaluronic acid, which is more of a lubricating shock absorption injection. But we also do biologics such as PRP, platelet-rich plasma, more so than we do stem cells, but some people do stem cells in their office. And if all that fails, then surgery and knee replacement is the way to go. So as far as injection therapy, we kind of went over that, the cortisone. And now we have some new long-acting, slow-release cortisones. The regular cortisone injections work very quickly, but you can't do them that often. And if you do too much of them, they can detrimentally affect the cartilage and cause it to wear out quicker. Again, the hyaluronic acid we've been doing for a couple of decades now or more, and it can be effective for arthritis. PRP, we do quite a bit of. What we have found is that doing the combination of the PRP with the hyaluronic acid really gives you the most bang for your buck. And then stem cells, which you get either from putting a big needle in your pelvis generally, or you can get it from fat, do like a little micro liposuction. Stem cells are found to be effective as well, but they're a lot more invasive, more expensive. And there's other kind of injections like prolotherapy, ozone. There's something called exosomes. And I'm interested in the exosomes, but they're not FDA approved, so they're really illegal to do at this time. So a lot of options out there with injection therapy. And if that all fails, then we start talking about joint replacement. And the number of joint replacements keeps going up and up. A lot of this has to do with the baby boomers getting older. But there's probably about 1 million total knees done in America on an annual basis now. And the reason is life expectancy. We're living longer. COVID put a little dip into our life expectancy for a while, but it's starting to go back up. And now everybody's interested in longevity and wants to live to be 150 years old, which I'm not a big believer in that. I don't know if that's the best thing for the world or if it can handle it, but either way, we are getting older and we're staying active as we're older. Um, this is Fauda Singh, who was the first 100-year-old to run a marathon, and he did several marathons after 100. Obesity in the past used to be an issue, but now with all the semaglutide medications, it's pretty easy now to take a pill or do an injection and lose weight. You don't have to work at it as hard anymore with diet or exercise. But still, overall, a lot of America is obese, and that's just going to put more weight on your joints and cause them to wear out. And this is what arthritis looks like, bone on bone. This is looking straight onto a right knee, so femur, tibia. Um, and if you have it just in one part of the knee, so the knee has three compartments, the inside or medial, outside or lateral, and then what we call the patellofemoral. If only one is involved, you can get by with doing a partial replacement. You can see the metal here, plastic metal, and this is what it looks like on x-ray. And we do a lot of these partials with the robot, the Mako. I started doing the robotic surgery in 2010. I think I was the first one actually to do the robot between Denver and Salt Lake City back in the day. Now the robots are everywhere. And the Mako was the original one. Now every company has a robot. But in our group, we have a lot of experience using this Makoplasty. And basically, the technology, you do a CAT scan, you can put the components onto the computer screen right where you want them. And that's a partial knee. This is if we do a total knee, that's where our components go. And then at the time of surgery, we basically are able to communicate with the robot with these infrared light. And these are the components for a partial. That's what a partial looks like postoperatively. And partials are less invasive than a total. Feels more like your knee, but not everybody. You have to have good motion, good stability, not a lot of deformity. And this is somebody that was 4 weeks post-op and they were doing great. But if you have more advanced arthritis, then you need a total knee replacement where we go in and replace all three compartments. Again, we do it robotically. These arrays, we attach one to the femur and tibia, and it allows us to communicate with the robot and the computer. And really the beauty of the technique is that it allows us not only to cut the bone perfectly, but it allows us to customize the procedure to each individual patient because everybody has different anatomy. So it allows us to dial in our soft tissue tensioning so our patients aren't too loose or too tight when they straighten or bend. And to me, that's the most important part of the software and the technology, besides being able to cut the bone perfectly every time. And this is just me. You can see I'm looking at the computer, and the green is the bone that I want to cut. And the way this haptic system works is that it won't allow my saw blade to deviate from that. So if it gets even less than a millimeter off, it'll shut off. So it will not allow me to screw up those cuts. And then once we cut the femur and tibia, we put our components on and we're done. Usually the surgery from time I cut skin to where we have the dressing on takes about an hour 20, hour 30 minutes. And the scars aren't too bad. And people generally in my practice are able to ski, play tennis, play pickleball, hike, bike, pretty much do whatever they want. The only thing I request is that they don't run for exercise because I worry that that repetitive impact loading could lead to loosening of the components. And these are all people that have had total knee replacements, from politicians, newscasters, rock stars, professional athletes that have gone on to be very active and do well after knee replacements. So what seems to work best for arthritis once the knee wears out? Physical therapy, exercise, diet, I think all of that is important. Over-the-counter medications can treat the symptoms, and decreasing inflammation may, to a certain extent, modify the progression of the disease, but mainly the medications and the injection therapy are more for symptomatic relief, probably not so much modifying the disease like people once thought it did. Correcting alignment, and we do that a lot of times with just simple heel wedges in our office. If somebody has arthritis on one side of the knee, unloader braces for tennis, pickleball, skiing sometimes can be effective as well. As I stated before, we do a lot of injection therapy in my practice, and that's simply done in the office, and it's not that big a deal for the patient. And if all that fails, then we move on to surgery, which is generally either a partial or a total knee replacement. And so I know I went through this pretty fast. I think that's my last slide. But I did that because I know people usually have a lot of questions, and I wanted to leave time to answer your questions. So I'd be happy to do that at this time. Okay.
All right.
What do we have?
So first question is for meniscus tears. Do you advise doing a cleanup surgery, and how successful are they?
Yeah, there's been papers and articles, even like I think in the New York Times and Wall Street Journal, that show that arthroscopy and going in and cleaning out meniscus tears doesn't work. Um, and I totally disagree with that, and so does the literature. For one, anatomically, if you have a tear in the meniscus, most of the meniscus doesn't have good blood supply, so it's not going to heal on itself. And in our population where people want to be active, you're going to put a lot of stress on that tear. So if you don't get it taken care of, you're just going to make that tear bigger. And if it gets bigger, then you're going to become more symptomatic. And ultimately, if you do have surgery, you're going to lose more of that meniscus. So there's a reason people come in and see us, is because their knee hurts. And if you have a symptomatic meniscus tear, I don't jump into surgery, but we'll try icing, we'll try anti-inflammatories, sometimes we'll try an injection, we'll try physical therapy. And if that doesn't work, then yes, I think going in and cleaning it out can be very successful. I always tell my patients, however, the caveat is that if you have any significant underlying arthritis or wear and tear of that smooth cartilage, that's really what affects the outcomes more than anything. If you don't have arthritis and you have a symptomatic meniscus tear, and you have a tear in that, what we call a white zone, where the blood flow isn't good, I'm very confident I'm going to make your knee bigger, and I'm going to prevent that tear from getting bigger and bothering you more down the road. But if you have some underlying arthritis, your knee still may bother you some. Some tears need to be repaired, like that one I showed you, what's called that bucket handle tear. People don't like that. They can't straighten their knee out. They can't put weight on it. It's painful. So yeah, if you have that tear, you need surgery no matter what. If you have what we call a root tear is where it tears way in the back. Those don't do well. If you leave those alone, the knee is going to hurt. It's going to limit your function, and the knee's going to wear out very, very quickly. So the root tears, we will repair. Bucket handle tears, you got to go in and do them. The gray zone are the ones that are kind of in that white zone. And do you need to do anything? And most of the time, people are symptomatic. I think going in and cleaning it up can be helpful, especially if they don't have much arthritis.
All right. And your next question is Mako robotic that you do. Is that a custom knee?
It's not a custom knee. So a custom knee is a knee where you do some kind of imaging ahead of time, like a CAT scan or an MRI, and then you wait 6 weeks or so, or 8 weeks, and the company will make a knee that's custom to your anatomy. And I've tried that in past. I'm not a big fan of that type of procedure. And the reason why is because you're doing a CAT scan or MRI of a knee that's not normal, it's deformed. So how do you know what the pre-arthritic anatomy is? So it doesn't really reproduce the normal anatomy, because how do you know what it is? However, the Mako is customized in the sense that I know what size, where I'm putting it based on the 3D CT preoperatively, and it comes in various sizes. And the Mako is now owned by a company called Stryker. And Stryker, there's probably more Stryker total knees in people than any other knee worldwide. So it's a very well-known, good knee that has a long history, well designed. But the way we customize it is really during the surgery. So even though we know where we're putting it, we know what size we're putting it, it's the soft tissue tensioning that allows us to get that soft tissue perfect is really where we customize it to the patient. And we're also able to customize the alignment, what we call the flexion of the prosthesis. So nobody has the same anatomy, but the software, even though it's a standard knee, allows us to customize the procedure to that patient's unique anatomy.
All right, and are there any fixes that you are aware of for patellar chondromalacia?
Patellar chondromalacia is tough because a lot of people have it. We see a lot of it, but the etiology of it is multifactorial. There's a lot of things that lead to chondromalacia. And chondromalacia is, by definition, it means softening of cartilage. So it's the softening of the cartilage underneath the kneecap and or the cartilage in what's called the trochlea, which is the groove that the kneecap rides in. And a lot of times it may be something very simple, such as having tight hamstrings. We know people that have tight hamstrings put more stress on the kneecap. But a lot of times, especially in women, it has to do with tracking issues. It's how the kneecap tracks in that groove throughout range of motion. And that can be due to if you have lower back issues, which can lead to hamstring tightness. It can be from tightness in the hips. It can be to what we call femoral aneversion, which is the way the hip is rotated. That can lead to tracking issues. It can lead to an increase, something we call an increase in the quadriceps angle. If you have a lot of knock knee deformity, that all leads to tracking issues. And a lot of times they can be very, very subtle. So treating chondromalacia can be very difficult. But I can tell you this, most chondromalacia, probably 80 to 90% of chondromalacia does improve with non-operative treatment, such as physical therapy, but not only working on quad strength or stretching out your hamstring, but strengthening the hip rotators, core strengthening, all that can be very, very effective for chondromalacia. And depending on how bad it is, some people get what we call crepitus or crunchiness under the kneecap, depending on your age. Then injections can be helpful also. And if people really have a lot of what we call mechanical symptoms like catching, if it's not just softening, but if it starts leading to wear and tear, then besides injections, sometimes actually going in arthroscopically and cleaning that out. And if there are alignment issues, addressing those alignment issues at that time can be helpful.
And final question for you. How do I make an appointment with you?
It's very easy. You just call 970-925-4500. So that's the number to our Aspen office. But there's always someone there during working hours to answer the phone. So 925-4500 is the number. And I see patients in the Aspen office at least once a week, usually more. And I see patients in our Willits office right across the parking lot there from Whole Foods on the second floor of that building, where Valley View has the Valley View Health Center there. So 925-4500.
All right, thank you.
All right, I guess that's it. Thank you guys for your attention, and we'll see you next time. Bye-bye.